Sorry, I was I'm trying to keep us all on time. We do have time now for some questions. Just as a reminder, if you have questions, please go to the peds.cnf.io, choose PEDS 21 and put your questions in there. While other people are doing that, we do have several questions already. There's a number of questions around the prescription of Suboxone. And I think one asked, do you do it or do you have a counselor in your office? When do you choose to refer? How do you choose to refer? And as part of that, how young of a child can you use it on, and are there age restrictions?
All right, so yes, I do prescribe it. And the counselor in our office is to augment the treatment with substance use counseling. Tomorrow in my talk, I'll give more specifics about that, but essentially the data shows that prescribing Suboxone alone in the absence of counseling is an effective treatment. But you see improvements when you have patients involved in both counseling or something as simple, Narcotics Anonymous. So you don't need to be in formal counseling to have an effect. And age restrictions. The FDA says 16 or older. Personally, I have not treated younger than 17, but I know that at the substance abuse clinic at Boston, they treat people as young as 13 who have opioid use disorder.
There's a couple of questions for Dr. Brown. One is, are aromatherapy oils judge safe? And actually, I know many of you use this, so anyone who wants to answer it. Is there concern about lipoid pneumonitis, particularly because of the history around vaping and stuff? I think there's a concern about aromatherapy oils.
Hello, okay. Yeah, so, that's a great question. So, and I didn't get to say how I recommend we use the oils. So in general, we do not recommend ingestion of the oils. I say, do use common sense if you're like cooking with lemon oil. I'm not saying that you can't do that, but, and peppermint oil is used for GI, but in general, we don't recommend that. When I talk about inhalation, we are not talking about like vaping the oils. We're literally talking about just we have something called a nasal inhaler that we use sometimes, or we put some drops of the oil on a cotton ball or on a Band-Aid that they can then, put on the inside of their clothes. There are sometimes the essential oil necklaces that kids like to have. So they're not directly getting in the vapor of the oil. Absolutely, I would not recommend anyone do that. I would be very concerned about a pneumonitis if you're actually inhaling the vapor of an oil. That's a great question.
Question, I think for Dr. Kundu, how do you advise patients and or families who are asking about CBD oil or marijuana products for chronic pain?
Yeah, that's a really good question. I know. That's what I say to you too. Good luck. What I would say is I think it comes back to the conversation that we had this morning with Dr. Gonzalez, I believe. It's like, have an honest conversation, engage them in a conversation, never just, even though I just said there's absolutely no role for it because we have no information on it that is consistent with pediatrics at this point. But don't open with that. What I would say is ask them what they're doing, how they're using it, and what kind of effects are they getting. And it is kind of the same I use for opioid use as well, right? So I think your goal should be functional improvement at a stable dose, and there should be, just as we talked about integrative medicine, is there benefit, is there detriment? And it's easier for some of these integrative therapies to determine that, but CBD, we don't have that data yet. We are still looking into it. The only evidence we have is for some neuropathic pain and especially with multiple sclerosis or neurodegenerative diseases that we've done in adults only. And so, but we have enough data to actually show us that there are very limited CBD receptors, not CBD, cannabinoid receptors, the CB1 and CB2. So CB1 are the only ones that are helpful in slight analgesia, and it's only to the degree of like the effect that we get with Tylenol and non-steroidals, or maybe even less. So I think that's one of the things that we have to have that conversation with them is risk versus benefit ratio, really. And plus, the other bigger issue is, at least with other medications, we know that the quality of medications that are available, we have a control. We have some way to know what's coming. As we all know, that there's no quality control for these CBD oils or any of that available commercially at this point. As a matter of fact, any of the marijuana products that are available today are 12 to 20 times more potent than their natural ones that were even available back in 2012. So those are some of the things that I would have conversations about.
I think Dr. Hayes wanted to make a comment on that
I
too.
actually had a question.
Oh, go ahead.
I actually have a question for Dr. Brown. As pediatricians, we certainly care for adolescents and young adults who are eligible for military service. Give us the 30-second tutorial on military acupuncture. I was blissfully unaware there was such a thing.
So I don't know if there's a 30-second one. So I do think that a lot of the people who are doing the training were using it in the VA hospitals. But I'm also told that there is something they're teaching called battlefield acupuncture. I don't think we're supposed to plug our sections, but I think next year we're going to be teaching that at our section if people are interested. But there is a particular pattern of needles that people can be taught to be put in the ears. Kansas is developing a program that they can use to teach in the, Anna Esparham is developing a program that she's thinking about rolling out to some of the other ERs. Shulin Sai is also one who has done some ER work there. So I just mentioned their names because you can then look in to see, you know, their studies on it. But it's something that can be taught in a very short time.
There's also several questions for Dr. Reynolds regarding what is the ultimate plan of care with your patient, Nate? He's obviously getting older. How do you handle transitions of care? When will he age out of your office? And what will be subsequent arrangements for a patient like him?
Good question. So we're sort of in uncharted territory in our practice. And actually, Nate's dad had this same question for me recently. Nate, right now, is going to remain my patient for the foreseeable future. What I'm hoping to transition him to at some point is another primary care physician who provides this service in their office. There are a few in our area, but none that I have really had a good opportunity to meet and talk with. So this is a situation where there will definitely be a very warm handoff between myself and whoever ends up taking over Nate's case.
Thank you. More acupuncture and complementary medicine related questions. Big ones around how do you get paid for it? How much does it pay? How do you get reimbursed? So I know both of you at the end there do acupuncture and mindfulness and complementary. So we'll start with Dr. Brown.
Sure. So I can tell you. So we bill based on time, and I think that I get paid just like if someone's prescribing an opioid. If I'm treating their pain, I'm treating their pain, and whatever tools are appropriate for that patient are used within that visit. So we bill based on time. And yes, so we get paid just like any other subspecialty. So part of my time I do pain management, part of my time I do palliative care, part of my time I do integrative medicine, and get paid the same.
So the only thing that I would add to that is acupuncture does have codes for like CPT codes that you can use to bill, and they're time-based usually. But obviously, if you're doing assessment and the procedures, you can also add a modifier to that. Not all insurances will pay for it. Not every state has even same insurance in different states will have different reimbursement issues. There will be some practices that do out-of-pocket sort of reimbursement. They'll basically say out-of-pocket expense, but usually I'd say that that's very expensive within the hospital setting because then they have the facility fee and all the other things that get tacked on, unfortunately. But there are community acupuncturists. There are lots of cities that are offering community acupuncture where, you know, licensed acupuncturists will offer packages of, you know, 5, 6 treatments, which is what you need for acupuncture for chronic pain. And they can range anywhere between $5 to $20, and it's basically multiple people having treatments at the same time. So those are some of the things that you may want to explore in your community.
This one's for Dr. Hayes. Do you worry? Do you worry at all about the addictive potential with ketamine? You talked about that as a modality.
Absolutely. When I started as an anesthesia resident, there were big vials of ketamine in the medication room that were completely not controlled, and because of its psychotropic effects, that's part of what led the FDA to make it controlled in '99. I think most people in this audience probably know that the FDA just gave approval for a medication that goes by the brand name of Sprix, the little nasal spray, which carries an approval only for depression. So it's only going to be used for depression, right? Not. Yes, I do. Ketamine's a fascinating drug. If you've ever watched a teenage football player getting their shoulder set in the emergency room, they sort of look at you and say, wow, that's the worst pain I've ever felt in my life. Boy, that really hurts. Are you going to eat that donut? I mean, there's a fascinating lesson in it, which we've never been able to tease out, because they know that they hurt. They just don't give a flip about it. Yeah. There are more data, as you might expect, on PCP, which really was marketed as a general anesthetic named Cernal. I think the right answer is, I don't think, and maybe the cannabinoids are a good analogy, I don't so much worry about addiction. I worry about side effects. And you hear about people who were PCP users who had terrible psychotic trips and had significant long-term psychopathology that may or may not be reversible. So as somebody who doesn't have training in addictionology, I don't worry so much about addiction with it, because I don't think we know to what extent you can get addicted to it, although you probably can. I worry more about long-term neuropsychotropic effects, about which we know almost nothing.
Do you use clonidine, or do you see any use for clonidine at all? You talked about dexmedetomidine for use in acute pain. Is there any evidence to support that?
Yes, there is. Clonidine is obviously a much older drug, and since it's one of the ones with which I grew up, I tend to like it. The residents sort of kid me that I'm Dr. Anti-dexmedetomidine, mostly because it's just so ferociously expensive, so I try to avoid it when I can. Clonidine's a great drug, and it's poor person's dexmedetomidine. Its roles sort of have a dual life. In the acute setting, because it's so relatively long-acting, it's difficult to titrate. So you give someone a dose of oral clonidine, for example, and it's an hour or two before they're really stoned. And it lasts for a long time. So in the acute world, clonidine is probably used most often with the interventional techniques. And in pediatric anesthetic practice, one of the common ways of doing it is to do it in a caudal block, the southernmost kind of epidural block. And there are pretty good data that it modestly prolongs the analgesic effects of a caudal, not quite so much as adding an opioid to it does. So acutely, clonidine is used more with the interventional techniques and less as a systemic agent because of its pharmacokinetics. If you think about that, though, for chronic pain management and for addictionology and for weaning. It's a wonderful drug for that because it lasts forever. And so it's a great drug to try to blunt opioid withdrawal and to wean people off of opioids. So yes, it can be used both acute and chronically, but it tends to have dual roles because of its pharmacokinetics.
Speaking of addiction, how long does it normally take to wean off of Suboxone? I know obviously in this case he has an acute injury on top of it, so that's going to affect all of that. But how long would you have expected it to take to wean him off? Is it a few months? Are you looking at years?
So I think that the answer is that every case is different because you have a lot of factors when you're weaning off Suboxone. One of the things that you look at when you're in the maintenance phase, so that's the long-term treatment of addiction, is you're looking at things like what stressors are there that could drive someone to want to use again. If we think back about Dr. Gonzalez's talk about sort of the multiple factors that are involved, there are some patients who never wean off it, and then there are others who do, but it's not a short time period. There are protocols out there where people treat for a few months and wean off quickly. Those patients tend to do worse. The best sort of evidence is that long-term treatment is important. I think it's not so much weaning off from the standpoint of you're not really worried about withdrawing as you wean somebody. What you're really worried about is relapse. And so that's what your primary focus is on as you wean somebody. Do cravings come back, or other sorts of, preceptors to relapse? So we're not talking about weaning in the sense that the first talk when you're weaning an infant with NAS and you're sort of monitoring for withdrawal symptoms. This is really you're weaning and monitoring for relapse, because that's really what you're looking for.
Thank you. So there's still a lot of questions on here, but in the interest of time, I think I'm going to ask one last question and then invite our speakers to stay and take your questions one-on-one. The last question is really, do you know, primarily for Dr. Brown, but others please chime in if they know the answer to this, is there a push by the AAP or others to work within the community to teach mindfulness techniques, to teach complementary approaches, mind-body connection techniques to school-age children, and to help really build their resilience and perhaps, treat or prevent or stop some of the despair that leads to the issues with addiction in the first place?
I love that question. Thank you for asking that. What a great way to end today. So I will say that, and we have our chair here for the section of integrative medicine. We absolutely do have an interest in looking at ways to do that. We do have some members who have significant research in that area. So Erica Sabinga is one. She's at Hopkins, and she has done a lot of research in that area. And Melanie Gold is in New York, and she has done some as well. So those are two people that you can, Google their names and look into some of the work that they're doing. But I think, you're absolutely right. This is really about empowerment, and it's about giving kids tools that they can use. It's not about fancy, expensive stuff, which is what people think about when they think of integrative medicine. This is about what strengths do people have within themselves that we can help them grow and develop and learn to be able to use to have a healthier and happier life.
Thank you so much to all of our speakers. I think this was I thought it was a fantastic session. Thank you all for staying and asking your questions, and hopefully our speakers have some time to stick around for a few more minutes to answer any other questions one-on-one.